Alrighty.
Okay.
Yeah. Welcome everybody to the second day of the expo. Thank you for coming, and I'm sure you've went to some pretty good talks here and learned a lot. So for this next hour here, Dr. Olaya and myself will be talking about pediatric epilepsy surgery. I'm Dr. Tran. I'm the current director for the Epilepsy Center here at CHOC Children's Hospital in Orange County.
I'm Dr. Joffre Olaya. I'm a pediatric neurosurgeon here at CHOC Children's Hospital in Orange County.
Okay, so we'll just do we have some slides. We're going to go over some basic information here, and then at the end we'll open it up the floor to some questions and answers. Alrighty, so Dr. Olaya will start us with some fun slides here. Great.
So again, today we're talking about pediatric epilepsy surgery, and obviously surgery for anybody can be very scary. We've all been living in very scary times lately, and I think a lot of what scares us is the unknown. You know, when coronavirus started, we didn't really know how things were going to progress and how things were going to develop over time. And we still don't know. We're still learning. And even today, you know, I think people are scared with the election because we don't know what the outcomes are going to be. But ultimately, we know that knowledge is power. And so the more that we learn, the more that we know, the better prepared we are, and the more confident we are with whatever potential treatment options we may need. So it's really important to come to events like this and participate in these types of events to learn as much as possible, you know, to see, because at some point surgery may be an option. And so, but the more you know about it, the better prepared you'll be, and the more informed you'll be. So Dr. Tran's going to give a brief introduction as to how the process works when we start thinking about epilepsy surgery in general.
So it's just a guideline of what we're going to talk about already, and I'm going to spend some time to give you some information on how to be the best advocates for your child already. Everyone comes to these events wanting to learn more, wanting to gather more information, and really it's so you can be the best advocate for your family member. And that's where we are trying to achieve today, is to be able to provide information and guidance so you can be the best advocate for your child, because that's why we're here for, to win this fight against epilepsy. Okay. And so a lot of times the first question I'll start out with, when should we consider epilepsy surgery? Alrighty, that's a very important question to consider in terms of when should I be starting to talk about surgery, or when should I be considering it? So when you're sitting in your office and your neurologist is talking about adding a third or a fourth anti-seizure medication to your child's medication regimen, that's when you should ask them, hey doc, is it time to consider surgery for my child, since we're talking about adding a third and fourth medication here because the first two hasn't worked? And that's when you should ask, are there other options already? Whenever a child or a patient is still having seizures despite having tried the first and the second and talking about the third or fourth medication, that's why as physicians, when you think outside the box, what are other options? And this is where you as parents can be an advocate for your child and say, hey, is my child a surgical candidate? And if they do say yes or they say no, you say, well, I'd like to get a consultation at an epilepsy center. At least this is not, now I'm talking with my mom hat on, okay? I'm a physician, but every now and then my parents know in the clinic visits, I always say, as a parent, this is what I would recommend. So at this point, as a parent, I would say, it doesn't hurt. Can I go get an epilepsy consultation for my child at an epilepsy center? And the answer, it doesn't hurt to go get at least one clinic consultation so you know what options are, okay? So there's always options. There are always, what are our options for my child? Because we want to stop the seizures, and the sooner we do it, the better the outcome. So you really want to garner yourself with the right information and talking to the right people to get the right information options for your child. And the best way to go about finding the right center or the right place to go is to find a level 4 epilepsy center. And the way you can go for it is, where do I go? Do I just Google it, like epilepsy centers? People, professionals have gotten together and tried to make this process easier for you. And there's an organization called the National Association of Epilepsy Center, or NAEC. And on the slide here is the website for it, okay? And this is a organization that establishes standards of care and what is needed to provide highest quality epilepsy care, okay? So it consists of professionals who are well-trained in epilepsy, has a lot of experience saying, for a center to provide quality care, this is what they need. And these centers have to meet criteria. Every year we have to go through and submit applications to maintain this accreditation. And if we meet that criteria, we are granted the title or to be called an NAEC Level 4 Epilepsy Center. Okay, so this is where this is the first stop. Where to get an epilepsy consult, go to this website and look on there where the local Level 4 epilepsy centers are in your area. And by going there, you know these centers are recognized and have gone through the rigorous accreditation process to know that that center provides quality care, highest quality epilepsy care. And when you go on that site, you'll see two different types of centers, okay? You'll see Level 3 and Level 4. The difference with Level 4 is Level 4 centers can do surgery and is certified to do pre-surgical evaluations. And Level 3 centers are able to do EEG monitoring, but are not able to do surgery quite yet, okay? And so you want to get, if you want the highest quality consultation, you look for a Level 4 epilepsy center on this website. So you go to that center, you go to this website, you put in Orange County, you'll see CHOC Children's Hospital on there as a Level 4 center. Okay? And so when you come to a Level 4 center, you'll be meeting an epileptologist in your first clinic visit. And people ask, what is an epileptologist? And you pretty much already know, and through the last 2 days here with an epileptologist, but essentially just to review, is a neurologist who have additional training in epilepsy care and epilepsy surgery evaluations, okay? So we are doctors who have a vested interest in providing good epilepsy care and have extended training for additional year or two to learn more about epilepsy care, okay? So when you meet us in our clinic, we're gonna get a history. We're gonna get to know your child. I always tell my parents, no one knows your child better than you. Parents and caretakers know their child the best. And that's where we start. We start with the history. When did your seizure start? Get to know your child. And once we get that information about an hour or two long consultations, we'll start talking about, okay, let's talk about your epilepsy roadmap. I've gotten a really good information about your child now. Let's start this roadmap on your epilepsy journey to know what are our options coming up for you to get control of these seizures, okay? And typically the first step after the in-clinic consultation is a phase 1 study where you come to our epilepsy monitoring unit to get an EEG study. And people ask, well, what is this, okay? This is the process evaluation here, and I'll go through each and one of them over the next couple of minutes here, okay? An EEG, essentially, I often tell parents, I wanna know everything about your child's brain. Right now in the clinic visit, you gave me a great history about what the journey so far, what you've gone through so far, what mess you've tried so far. This is really good. The next step is I want to understand your child's electricity. Okay, your brain functions by electrical currents. I want to understand the electricity in your child's brain. And the best way for me to do this is to do an EEG study on my epilepsy monitoring unit. And so when you come to the unit, that EEG that your child puts on the head for like 30 minutes or so for outpatient, it stays on for the entire hospital stay. This way, I can understand what your child's electrical activity is during awake, during drowsy, and during the different stages of sleep. And more importantly, if your child has abnormalities in between seizures and where they are, and also, of course, capture seizures, right? Because when I capture a seizure, I can know where the seizures are coming from. Is it coming from one area of the brain and then spreading, or the entire brain at the same time? So that's very important information because it sets the stage for me to understand what are the best options to control these seizures, okay? So in a way, with the EEG, that's the time period to have seizures. A lot of parents go, I don't want to see seizures. Like, yes, I don't want seizures at home, but once you're in the hospital in my unit, I need seizures. And so we'll do certain things like stop, discontinue, hold medications, sleep deprive your kid, do certain things to bring out seizures because I want to see the seizures because like I said, it sets the stage for me to make further recommendations. So based on that evaluation, that phase 1 study, if we say, oh, okay, your child is an epilepsy surgical candidate, we're going to go on and do some other studies, okay? The next, so on the EEG, I understood your child's electrical activity. The next thing I need to understand is what the brain looks like. What does your child's brain look like? Are there areas that form right, or has there been injury from prior brain prior trauma or whatnot? That's where our brain MRI comes into play, okay? The brain MRI is a way for us using magnets to take a picture of your child's brain in a very high resolution. A lot of times people go, well, is any type of MRI okay? I'm like, actually, for us, we prefer a 3T or 3 Tesla MRI. The difference is when you go to Costco, you can see when you're on the different screens at Costco TVs, you see like different qualities, right? Some certain resolutions, a 4K resolution, so much better than the 1040, 1040 system. So same concept. A 3T MRI shows me a very fine detail of your child's brain, which adds a lot more information for me to see if there's areas of their brain that formed right or didn't form right, or areas of brain that did have prior injury causing scar tissue now, therefore causing seizures. So the brain MRI is a way for me to have a picture of your child's brain to see what it looks like. Another one is, another study then after the MRI that's important is called a PET scan. The PET scan, the best way to understand what the PET scan is energy. Okay, so I understood what their electrical activity is by the EEG. I got to know what your child's brain looks like by the MRI. I need to understand how your child's brain uses energy. But it's important because areas of the brain that causes seizures uses energy differently than areas of brain that do not cause seizures. And this information can be elucidated by a PET scan, where your child gets an isotope injected that's tagged to sugar or glucose. Brain uses sugar for energy. So areas of the brain that use energy abnormally takes up glucose different than areas of the brain that uses energy normally. So therefore the signal is different on the PET scan, and therefore it adds more information. So a PET scan gives me information about how your child's brain uses energy. Alrighty? So that's one puzzle. Another big important puzzle is a neuropsychology evaluation. What is this? Well, we understand a child's brain does a lot of things, right? There are parts of their brain that's involved in memory, parts of the brain involved with speech production, language, understanding, parts of the brain that controls ability to maintain attention and behavior and planning and all that. All that information to tell if there's parts of the brain and how they function can be assessed via neuropsychology evaluation by a neuropsychologist. And this is also another tip of information here. When you go to your centers, ask if that neuropsychologist that's performing this test is familiar with children with epilepsy. When there's neuropsychologists who work closely with epilepsy patients, they understand the interplay, the effects of continued seizures on the brain. And therefore, when they do these evaluations, they understand the effects of medications, they understand the effects of seizures, how often, how long the child's been having seizures. All that gets summarized in their summary after their evaluations. That is important. So another tip is when you go getting a neuropsych evaluation, not just by any neuropsychologist, ask, is this psychologist a pediatric trained? And number two, are they familiar with kids with epilepsy? Those are important tips that kind of let you know if you're having a good quality evaluation. Okay. So after we get all this information and the data, all of us, all the brains in the center get together in a room and have a surgical conference to discuss the data and the patient, okay? So this is what most conferences look like. But Dr. Olaya thinks conferences at CHOC looks like this. Alrighty, we are a children's hospital, so we work with kids and we try to make things fun, but we also work hard at the same time, alrighty. So we get together, we talk about the case. Everyone gives us their input. It includes the epileptologist in the group, as well as the neurosurgeon, the neuropsychologist, neuroradiologist. Everyone in the area of specialty gets together and talk about the case. And we come up with a consensus in terms of what is the best management, what are the options for this child, okay? So after we get our consensus, we will reach out to the family. Most centers operate like this. Here at CHOC, after our conference at our surgical conference, we'll have a family conference where you meet with us in epilepsy, the epilepsy doctor, as well as a neurosurgeon, all in one room with your family to discuss, this is the information we have so far. We've talked about it with our group, and this is our recommendations moving forward. Whether it is doing further monitoring with phase 2 monitoring, or is it other options? And at this junction, I'm going to hand it over to Dr. Olaya, because this is where we talk about the next process. And in surgery, if surgery is an option, if so, what are the next steps? And often parents have more specific questions about the surgical process itself. And this is where Dr. Olaya can help out and answer those questions in the visit.
Thank you, Dr. Tran. So again, as Dr. Tran mentioned, surgery can mean lots of different things. Surgery can mean we need to get more information. Again, the MRI, the PET scan, the EEG, the neuropsych testing gives us an idea of where the seizures are coming from, but sometimes we need to be more precise. And so that's where we may need to do the phase 2, as she mentioned, which means we put electrodes directly on the brain to monitor procedures. Sometimes we do resections or disconnections and lots of different other modalities that we have. So I'll briefly go over some of those different techniques. So clearly, the literature has shown that for patients that have failed 2 or more seizure medications, epilepsy surgery has a greater chance of giving seizure freedom and seizure control than if just continuing to try a 3rd, 4th, or 5th medication. And not only is it important to consider epilepsy surgery if you failed a couple seizure medications, but it's really important to try to do surgery early, because we know that through studies that the earlier you do surgery, the better long-term seizure outcome. And then obviously in our pediatric patients, it's important to be able to give our children the best chance of brain development. It's a very critical time in their life, and want to make sure that we control the seizures as best as possible so that the brain is able to develop to its fullest potential. So again, as I mentioned, sometimes we'll do monitoring, and that monitoring entails placing electrodes directly on the brain. This is what the grid electrodes and the depth electrodes look like there. Dr. Tran, can you see my mouse on the slides?
Yes.
Okay, great. So these are the strip electrodes, and then these are the depth electrodes here. And then the grid electrodes, we place those by making an incision, opening up the skin and the bone, opening up the dura, covering over the brain, and then we place the electrodes directly on the brain. And we tunnel the tails, the wires of the electrodes out, and then we close everything back up. And then just like with a BTM, once the electrodes are in place, we want to be able to capture seizures. So we want to see the seizures so that Dr. Tran and her team can then help figure out exactly what part of the brain the seizures are coming from, and then we can determine what the next step in treatment will be. I mentioned we can put electrodes directly on the brain, but we can also put them directly into the brain, and we can place them using a robotic navigation arm. And the system that we use at CHOC is called the ROSA. It's a device that looks like this, and this is a robotic arm that has a computer attached to it. And so prior to surgery, I can plan exactly where I want to enter and where exactly I want the electrodes to end up. And all that is based on the preoperative workup that's been done with Dr. Tran and her team, so that we can find precisely where the seizures are coming from. And so this is what the robot looks like in the operating room. And then the robotic arm will go to the entry point where we planned, and then it places the cannula so that we know the precise entry point, and we know the trajectory that we need to take so that we can safely put in the electrode into the brain. Obviously, we want to avoid causing any damage, so we take a lot of time planning it out and making sure that we're avoiding any blood vessels so that we don't cause any injury along the way. And these are the instruments that we use in the operating room. So we have, there's a stylet, so basically create a channel down into the to the target. We're able to measure the computer itself on the robotic station calculates based on where the arm is in relation to the head, how deep we need to go, so then we can measure that and mark that precisely on the electrodes. And then this is basically there's a little bolt that goes in place to help secure and keep the electrode there in place. And then afterwards, this is what it looks like. And then we can have electrodes all throughout the brain, and then we're able to sample throughout the brain and to help figure out where the seizures are coming from. And this is particularly useful when it's not clear if seizures are coming from one side of the brain or the other, because as we talked about before, with grids and strips, we place those directly on the brain, but it's also challenging if you want to place electrodes all around the brain, because then you sometimes can have a little bit of swelling and things like that. And so the more electrodes you place directly on the brain, the more potential issues you could have. And so by placing the depth electrodes, they're much smaller, and so less chance of swelling and other problems. So this really gives us an advantage in certain situations, particularly when we're looking at bilaterally or on both sides. That was one type of surgery, is just to gather more information. Sometimes, and then once we gather information, we could resect that particular area or treat that with different modalities. In some cases, it's more straightforward. You can have a patient like here, for example, that had the whole workup that Dr. Tran talked about, the EEG, the MRI, the PET scan, and everything pointed to the seizures coming from this area. And we could see that there was a lesion there. So we did a procedure, and then we resected that area, and then the seizures have been controlled ever since. So that's pretty straightforward. But occasionally it can be a little bit more challenging. Sometimes if the seizure focus is close to an eloquent part of the brain, so a part of the brain that helps control language or motor movement or sensory function, then sometimes we'll have to do mapping. So again, this is what the electrodes look like on top of the brain. And you see there's little numbers on there. And these are the tails or the wires that are coming out. So once we place that, we close everything up. Patients will go up to, back to the intensive care unit. We'll monitor it there, and then go down to the regular floor. And then Dr. Tran and her team would then be able to stimulate the different electrodes to help elicit function. So you can stimulate particular areas, and if you start seeing movement, then you can say, oh, that area corresponds to the motor function, for example. And then also at the same time, we're also capturing seizures. And so at the end of the whole process, then we can delineate and say, okay, this is where the motor area is, this is where the sensory area is, and then we can say, for example, the seizure focus is here. And so when we do the next step, perform the next step, then we obviously try to avoid causing damage to the functional areas while trying to resect as much of the epileptogenic focus as possible to give the best chance of seizure control and seizure freedom. Another type of procedure that we do is a disconnection. Now, there's different levels of disconnection that we can do. In this particular patient was a patient with tuberous sclerosis that had seizures coming from both sides of the brain. And so here we did what's called a corpus callosotomy. This is a view looking from the side, the MRI. You can see the nose is here, the mouth would be down here, here's the forehead, and here's the back of the head. So there's a slice right down the middle. And so this white structure that you see here right in the center, that's the corpus callosum. So that's one of the big connections from one side to the other. And so in this particular case, patient, we performed a craniotomy. So we made an incision, opened up the skull, and then we went between the two hemispheres, in between the brain and down to the corpus callosum, and then we resected or disconnected this whole area. And so this is what the MRI looks like afterwards. And so you can see the white tissue there now is gone. And so then that helps in these in certain types of seizures where the seizures spread really fast from one side to the other, and helps decrease that seizure frequency. Now, this isn't a curative procedure, so it doesn't take all of the seizures away, but it helps decrease the frequency and the severity, and helps decrease the seizure burden overall. Now, again, this is what a standard procedure looks like. So here we're looking actually right in between the two hemispheres, the two halves of the brain, and we're going straight down. And so you can see one half of the brain here, the other half over here, and then that's that white structure that I was showing you before. That's a corpus callosum. So we can see here we're starting to dissect through that tissue. And this is another picture, just from a different angle, looking at the same thing, just looking at that disconnection. Now, more recently, it's been described doing these procedures in a more minimally invasive fashion. So again, we're trying to give the best seizure outcome, but we also want to make sure we minimize any neurologic deficits or problems postoperatively. So we try to do things minimally, the least invasive way possible. And so one of the newer techniques that we can do for a corpus callosotomy is using a laser ablation system. And so this is a video from one of the company's websites demonstrating what this laser ablation device looks like. But essentially, this patient is lying here on the MRI table. This is just the coil that's over the patient's head. So when somebody has an MRI, they put this device over to be able to get the signals. And then here we can see this is after the patient's already gone to the operating room. And typically we use a ROSA, the robot that I showed earlier, to place a little bolt in the precise entry point in the trajectory that we need to get down to where the lesion or the area of concern is. And so once we do that, we come down to MRI, and then we attach this. This is another robotic system here that helps advance the probe and push it in or pull it out if needed. And then this is actually what the probe looks like here. As you can see here in the video, is that working there? Can you guys see that, Dr. Tran?
Yeah.
And so you can see the probe going in. and then it's going down to the target. And then essentially in the MRI, we turn on the probe, and then we start heating the tissue. And then if you heat it for a certain period of time at a certain temperature, then we denature that tissue, so then it becomes non-functional. And the idea is hopefully to help destroy that tissue so that the seizures aren't propagating or spreading from there anymore. And so now we're using this technique for even for a corpus callosotomy, so we can place several probes to get that the specific trajectory that we need, so we can burn that tissue instead of actually doing an open procedure. So it's a newer technique that we have. Sometimes in other cases, we need to disconnect a larger area, so laser ablation may not be possible. This is another patient that has a lesion here. This is a CT scan, and you can see this bright spot down here. So this is a lesion on the brain. That's after doing the whole workup, we found that that's where the seizures were coming from. And so then we did a procedure as an MRI, and so this is the bottom part where the seizures were coming from. And so on here, you can see the eyes here, the face is on this side, and there's the back of the head. And so we did a craniotomy, opening, and we you can see here this darker line here. That's the disconnection that we created with an open craniotomy. And so separating the part of the brain that's causing the seizures from the rest of the normal, healthy part of the brain. And this helped control seizures for this patient. The biggest type of disconnection that we do is what's called a hemispherectomy or a functional hemispherectomy. So we do those procedures in patients that have a process that's affected the entire hemisphere, the whole half of the brain. So this is an example of a patient that had a stroke as an infant, and you can see damage on this side of the brain. So this is what the normal half of the brain looks like. So the brain is the gray area. You can see the white dots around are the different blood vessels. This black area here are the ventricles or the fluid spaces. And so you can see how the two sides look different. Here, the ventricles look much bigger. It's because the brain tissue here has kind of shrunken over time because of the damage from the bleed. And so for this patient, we did a workup and we saw the seizures were coming from the entire hemisphere. So it wasn't one specific area, but it was diffused throughout that whole side. And so then we did what's called the functional hemispherectomy, where we disconnected the frontal, the occipital, the parietal lobe from the rest of the brain tissue, so that abnormal tissue that's not functioning very well anyways isn't causing the seizures and then damaging the healthy, normal part of the brain. And this is one of the earlier patients that we did here at CHOC, and she's been seizure-free for 6 years now. So again, a hemispherectomy is one of the most effective surgical interventions the treatment of patients with unilateral hemispheric epilepsy, meaning that the seizure is coming from the one side. And there's lots of different variations and modifications on how to do the procedure, and they all have similar outcomes. But again, we typically like to leave some of the tissue there. We disconnect the abnormal tissue, but we don't take it all out, because we also know that many patients that have this procedure may develop hydrocephalus. And hydrocephalus is a condition where the brain isn't able to reabsorb the fluid that normally is able to absorb. So, we all have fluid in our brain and we're producing it all day, every day. But sometimes after this type of procedure, the body has a hard time reabsorbing this spinal fluid. So it's getting produced, but then it doesn't have anywhere to go. So the pressure over time starts building up, the fluid starts building up, and that can lead to headaches and vomiting and lethargy. And so to be able to treat that, then we place what's called a VP shunt or a shunt. And it's a catheter basically going into that fluid space in the brain that's connected to a valve, and there's a tube that goes under the skin down to the belly. And so if the pressure gets too high, then the fluid that the body can't drain will then go down the tube to the belly, and the belly will reabsorb it. So typically we see that maybe in about a quarter of patients or so that have the procedure. So it's just something to be aware of ahead of time. Now this procedure, obviously it's another surgery, but it's pretty well tolerated. It doesn't take very long, and typically patients go home the next day. So it's not a very invasive procedure per se. So I talked a little bit about laser ablation earlier for corpus callosotomy. Again, laser ablation can be used for lots of different things. Sometimes if you have a small focus in different parts of the brain, you can place the probe in that particular area and burn it. This is just showing the imaging study, seeing how we can target a specific point where we see the seizures are coming from. And then this is the system, the Visualase. There's a couple of different companies that we use that we can use for laser ablation. This is the Visualase system, And so this is the bolt that's screwed into the skull, and that's a little wire that's going down into to the target. And then once the probe is in place, and again, we'll go down to MRI. And so then these are the images that we can see on the computer system for the ablation system. And so on this scan, for example, you can see the nose is over here, the face is this way, and then this is the back of the head. And that gray line that you see there is the trajectory of the probe. And then the green, blue area there and the yellow area there, that's the area that's being heated. And so in real time, we heat the tissue, and then we take imaging MRIs, and then we look at the temperature, and then the systems are able to tell us once it's achieved a certain temperature for a specific period of time, and then we know that that tissue has been damaged and no longer should be functional or and causing seizures. And then, so this is a patient that we did a laser ablation for last year. And so this is what the other system looks like. This is the Montera system. So again, similarly, this is a view looking from the side. The face would be here. Here's the back of the head. This is kind of a view looking from the side. As you can see, this is where the probe is going into the target. So we identified this as a target where the seizure was coming from. And so instead of doing an open craniotomy and going in there and resecting that area, instead we placed a small probe, and then we can see again in real time the area being heated. And so this yellow line here shows us when the tissue is heated, but at this point the tissue is not, it's still functional, it's just a little bit warm. But if you keep heating it for an extended period of time, then it starts destroying the tissue, and then it's not functional anymore. And so we can go back and forth between this yellow line, and then you'll see here in a second, it'll switch over to a blue line, and the blue line is a little bit smaller. And so that smaller radius is where the tissue has been heated long enough right there. And so at that point, that tissue is non-functional. And so we go back and forth between the two because we need to heat a little bit of broader area than the region of interest. But we want to make sure, again, make sure we're not damaging any additional tissue outside of where the seizures are coming from. And so obviously this is a nice procedure because, again, we're not doing a big opening. It's a very small, a few millimeter incision, a few millimeter burr hole, and then we're just placing the probe down to the target and then destroying that tissue. And so you can see here, this is a patient a week after the procedure. You can just see that small area of hair that was clipped. You can just see barely a stitch that's there in place, and patient did great. So it's a nice minimally invasive option. Again, if you have seizures that are coming from a very small focal area. Again, if it's more widespread, then it may not be the right option. Now, in patients where we can't do a resection, we can't do an ablation, it's more widespread seizures. And we can also think about neuromodulation. That means that we're altering the electrical activity. And so a couple of different devices that we can use for that. One device is called the responsive neurostimulator, or RNS. The company is NeuroPace. And so this is a generator. It's a computer basically in there that's monitoring the electrical activity in the brain. And so similarly to I described before, placing the electrodes to monitor for seizures, we're trying to figure out where the seizures are coming from. Once we find where the seizures are coming from, if the seizures happen to be coming from a part of the brain that we can't afford removing, resecting, or ablating, because again, there's some functional tissue there, and we don't want to cause any damage, then sometimes we can place these electrodes over that particular area. And so then this device is recording the electrical activity over time, and then it learns what the seizure patterns look like. And so if it captures a seizure just starting, then it'll send a signal. It's basically like a pacemaker directly on the brain, and hopefully help stop or shorten the seizures. You can see that the generator itself gets embedded into the skull there, and then the paddles go directly onto the brain. So now this was approved back in 2013 for adults, again, for patients that were refractory or they failed 2 or more seizure medications. But probably since about 2014, 15, there have been centers that have been implanting this in pediatric patients as well. And so there is some data showing that this can be beneficial for pediatric patients as well, particularly if where the seizures are coming from is an area that we can't afford resecting or ablating. Another neuromodulation device is the VNS, or the vagus nerve stimulator. Again, this is also similar to a pacemaker in that it's sending electrical signals, but this isn't going directly onto the brain. Instead, it's a device that has a wire, 3 little coils that are wrapped around the vagus nerve, which is a nerve that goes along the neck here. And so then that wire then gets tunneled under the skin and is connected to a generator as well that's implanted into the chest area. And so that device is essentially sending signals throughout the day. And then those signals then go up to the brain. And then again, it helps kind of short circuit the seizures to help decrease the seizure frequency and severity. And so we can see that in general, we say that patients, more than half, about half to 2/3 of patients that have a VNS have a 50% seizure reduction in their seizures or more over time. And you can see these are different studies that they've done looking at the function of the VNS. And so this is at 1 year, this is at 2 years, this is almost 3 years, 4 years, 5 years. And so you can see that over time, you see that there's more of a response. So in general, about 2/3 of patients or so will get more than a 50% seizure reduction. So again, unfortunately, it's not a curative procedure, but for patients that are having seizures that are coming from lots of different parts of the brain and there's no specific area to treat, this can be very beneficial and helpful to help reduce the seizure frequency and severity. And the device works in 3 different ways. So one, as I mentioned, it's sending a signal throughout the day. But then in addition to that, if somebody's having a really long seizure, a really strong seizure, or multiple seizures back to back, a cluster of seizures, you'll have a magnet that you can swipe if you know the seizure is coming, or some people have an aura, or if somebody's having it, somebody else can swipe it for them, and they'll send an extra signal. And sometimes that'll help stop the seizure as well. In addition to that, we know that more than 80% of patients that have seizures have an increase in their heart rate right before the seizure happens. And so this device actually can detect that increase in heart rate, and then it'll send an extra signal, and then that sometimes helps stop the seizures as well. So there's 3 different functions to help control the seizures. And this is the newest device, is the Model 1000 or the Sen Tiva. This is the wand that we can use that we basically just place right over the chest to help program in it, and then this is the tablet where we can make the adjustments as necessary. So typically we place the device and then we put it at very low settings just to make sure that patients tolerate it okay and they're not having too many side effects. Then when I see the patients back in clinic in about a week, I'll increase it a little bit more, and then they'll continue following up with their epileptologist, and they'll keep titrating, just like with medications, keep titrating it up until we get to a point where it's controlling the seizures as best as possible. And then lastly, another type of neuromodulation is deep brain stimulation, or DBS. Now this is a device that's implanted directly into the brain, and then the wires are tunneled under the skin, and then again connected to a generator that's implanted in the chest area. You can see these are different pictures of the brain, and specifically what we're looking at here is the thalamus. So different centers have implanted this in different parts of the brain, but probably the biggest study that looking at DBS for epilepsy was called the Sante trial, and they were looking at the anterior thalamus. So these are different parts of the thalamus. It kind of looks like a football shape. And so they target the anterior nucleus, and then that's been shown to help decrease and control seizures. So essentially, after DBS is placed at 3 months, they saw about a 40% seizure reduction compared to patients who didn't have it turned on, only having about a 15% reduction. And then for patients that they followed long term, even up to 7 years, they saw up to a 75% decrease in their seizures. And so it can be beneficial for seizure control. Again, not curative, but it can help control seizures for patients that don't have other options. And so, again, as I mentioned earlier, there's been lots of studies showing that epilepsy surgery can be very beneficial for patients that have failed 2 or more seizure medications. Interestingly, even though that paper, one of the original papers came out almost 20 years ago, when people have looked back to see what the trends are and how many, after that paper, people started having more, or centers were offering or providing more epilepsy surgery. Interestingly, they saw there wasn't really a big change in the number of surgeries that were being performed for patients with epilepsy. So although the information out there, it's still not widespread. And I think, this particular paper was just commenting that I think what happens is a lot of times patients end up getting treated at centers that aren't level 4 epilepsy centers like Dr. Tran was talking about. And so they may not have the option of having these other procedures done to help control their seizures. They did a similar study looking at a pediatric database as well around the same period. And they found the same thing, that definitely not as many patients that should be having surgery are having surgery. based on the number. So again, it's really important to if somebody's failed 2 or more seizure medications and the seizures are not controlled, it's really important to start getting more information, learning more, and potentially getting referred to a level 4 epilepsy center that can talk about different options. And so, as I started to talk, obviously epilepsy surgery sounds scary. It's something that's very serious, but we do it regularly, we do it safely, and it really makes a big difference in a lot of patients' lives once the seizures are controlled. So it's definitely something to think about and learn more about. And so, as I mentioned, there's lots of different treatment options, there's lots of different technology and new technological advances that are coming out. As I mentioned, once somebody's failed seizure medications, the earlier we think about the surgery options, the better, because we know that leads to better outcomes. So I definitely talk to your providers and make sure you have the information that you need so you make the right decisions. Dr. Tran, do you have any other comments you would like to make?
Yes, thank you so much. So I hope you guys found this helpful to know about the different surgical options. We've gone a long ways. There is now more minimally invasive options now to do epilepsy surgery to decrease, make it more palatable. But the overarching goal, don't forget, is to stop seizures or to improve quality of life already. So everything you've heard about at this expo today, all the treatment options and what Dr. Olaya described and whatnot, our goal is all the same. We're all on the same page. We are here to stop seizures. We are here to improve your child's quality of life. And so don't forget that goal already. And what we should think about is be open to other options to see what we can do to achieve it, whether it be surgery or dietary or neurostimulation. Our goal always is to win the battle against epilepsy and to improve your quality of life. And the earlier we do it, the better the outcome, okay? And so on that note, we will stop here and open the floor up to any questions in case there are any questions. Do level 4 centers, okay, there's a question by Ruben. Do level 4 centers have a 3T MRI? Yes, most level 4 centers do have 3T MRI. That's one very good question you ask when you go get the consultation is, do you guys have the 3T MRI when you get an MRI for my child? So most, I don't want to quote wrong, but most centers that I know of do have 3T capabilities. Okay.
Dr. Tran, can we remind everyone, I'm going to remind everyone, if you move your cursor to the bottom of the screen, you'll see the chat box. And if you're shy, you can write your questions in the chat box, and that's where we're answering the questions. And I also took the liberty of putting CHOC's Epilepsy Center contact information there, so you can directly contact them for a consultation or to make an appointment. So please use the chat box for your questions. Thank you, Dr. Tran.
Oh, thank you very much. Alrighty, so Nancy has a question. My son had a brain bleed that turned out to be a cavernous angioma in December 10, 2017, and surgery to save his life. He had no seizures until October 4th of 2020, which came from scar tissue according to the EEG and Kaiser doctor. He's now on Keppra. He has had a few seizures since. Have you seen surgery correct this? Potentially, for sure, when there's been some brain injury due to a prior brain bleed and there's scar tissue, it can definitely lead to seizures. And if it is, depending on the evaluation and the results and the data that we obtain, surgery can potentially help control seizures again. And the one image that Dr. Olaya did put up was a child who did have a brain bleed and did have scar tissue. And was continuing to have seizures despite being on medications. And we did do surgery, and now she's doing wonderfully.